Welcome to This Explainer. Okay, today we're tackling something you literally see all the time, pharyngitis. We're going to deliver a really high-yield, scientifically accurate breakdown focused on that critical clinical divide between viral and bacterial causes, giving you exactly what you need for both your exams and your everyday practice. Here's our clinical roadmap for today. 1. Understanding pharyngitis. 2. Etiology, viral versus bacterial. 3. Clinical features and symptoms. 4. Investigations and diagnostic scoring. And 5. Evidence-based treatment plans. All right, let's jump right in.
Starting off with Section 1, Understanding Pharyngitis.
So before we get into the heavy diagnostic algorithms, let's just ground ourselves. Pharyngitis is simply inflammation of the pharynx, which, as we all know, walks through the clinic door as a sore throat. It's super straightforward, right? But keeping this basic physiological reality in mind really helps anchor everything we're about to discuss. Moving right along to Section 2, Etiology, viral versus bacterial. Figuring out the why behind the information is absolutely crucial because it dictates our whole game plan. Now, we often stress about bacteria, but the vast majority of these cases, they're viral. We're talking rhinovirus, coronavirus, adenovirus, influenza, and EBV. But here's the kicker. Never forget that non-infectious culprits can perfectly mimic an infection. Things like GERD, seasonal allergies, or even just environmental irritants can easily cause pharyngitis. So you've really got to keep that differential diagnosis wide open right out of the gate.
Now, when we do pivot to bacterial causes, Group A Streptococcus, or GAS, is the undisputed heavyweight. But context is everything here. In the adult population, GAS accounts for roughly 15% of cases. Think about that. It means a massive 85% of your adult patients actually have something else entirely going on.
But wait, that statistic shifts dramatically when we look at kids. The incidence rate effectively doubles to 30% in pediatric cases. That's nearly 1 in 3 children showing up with a sore throat actually having a Group A strep infection. This is exactly why GAS has to be front and center on your diagnostic radar in pediatrics. And while GS steals the spotlight, it's definitely not the only bacterial player. For those high-yield exam points and to just be a rock-solid clinician, you've got to remember the others. Keep Group C and G Streptococcus, Fusobacterium necrophorum, Archaneobacterium hemolyticum, and, really importantly, Neisseria gonorrhea in the back of your mind. A sexually transmitted infection like gonorrhea presenting as a standard sore throat? Yeah, that just proves why taking a complete, thorough patient history is literally non-negotiable. Okay, Section 3, Clinical Features and Symptoms. So we know the bugs, but what does the patient actually look like sitting on your exam table? Regardless of the underlying driver, the primary complaint is almost always going to be a sore throat paired with painful swallowing. That's your baseline. Your job isn't just to spot the sore throat, it's to look past it at the accompanying symptoms to actually solve the mystery. And here is the ultimate clinical showdown. Viral pharyngitis tends to be, well, wet and widespread. Cough, rhinorrhea, hoarseness, maybe even conjunctivitis. Group A strep, on the other hand, hits completely differently. We're talking sudden fever, nasty tonsillar exudates, and tender anterior cervical lymph nodes. And here's the golden rule. The absolute absence of a cough is a heavily weighted clinical indicator for GAS. If they are hacking and coughing, you're almost certainly looking at a virus. All right, Section 4, Investigations and Diagnostic Scoring. Because let's face it, clinical symptoms can be pretty subjective. So here's your evidence-based detective work to officially rule out GAS. Step 1, objectively score the likelihood of GAS using the Centaur or McIsaac criteria. These tools use those exact symptoms we just discussed to give you a hard mathematical probability. Step 2, if the score warrants it, confirm it with a rapid antigen detection test, or RDT, right there in the clinic. And Step 3, always keep a throat culture in your back pocket. It's still the absolute gold standard. Now, I want to give you a couple of really vital clinical pearls. First, if you've got a high-risk child with a negative rapid antigen test, our SOARS guidelines are clear. Always follow up with a throat culture. You just want to be absolutely certain you aren't missing a strep infection there. Also, if the clinical picture is whispering infectious mononucleosis, say a profoundly fatigued teenager, don't forget to order a monospot or EBV serology to lock down that viral etiology. Finally, Section 5, Evidence-Based Treatment Plans. We've looked at the symptoms, we've run the tests, and now it's all about responsible treatment stewardship. If your workup points to a virus, the treatment is 100% supportive care. We're talking analgesics, hydration, warm, saline gargles. Absolutely no antibiotics.
But if you have a confirmed group A strep infection, the evidence strictly dictates a full 10-day course of penicillin V or amoxicillin to clear the bacteria and stop those nasty secondary complications.
But here's a curveball you're gonna face all the time. You've confirmed GAS, you know you need antibiotics, but you open the chart and boom, massive red flag for a documented penicillin allergy. So how do you pivot?
Well, to wrap up this explainer, if your patient is allergic to penicillin, the guidelines point you straight to cephalexin, clindamycin, or azithromycin as your safe and effective alternatives. And as we finish our clinical breakdown today, I want to leave you with a thought. In an era where antibiotic resistance is quite literally one of our greatest global health threats, how rigorously are you going to apply these exact diagnostic criteria, like the center score and the ROD-T, the next time a patient walks into your clinic demanding a quick antibiotic fix for a simple sore throat? Something to chew on. Trust the evidence, and I'll see you in the next explainer.